Ever had that nagging ache that just, well, won't quit? Or maybe a bone felt like it gave way far too easily.
Hmm.
We're diving into a condition today that might shed some light on those experiences of osteomalacia.
Exactly. Yeah, we've got a really solid set of revision notes here on
Yay.
osteomalacia.
Hmm.
And our mission really is to pull out the key information you need to understand it and, remember the important bits about this metabolic bone disorder.
Right.
Think of this as your sort of high-yield guide, what it is, causes, management, the whole picture.
Okay, great. So osteomalacia. Let's get straight into it. What's the actual definition?
Okay, so put simply, osteomalacia means your bones become soft.
Soft bones.
Yeah, and this softening happens because the bone matrix, that's like the underlying structure, it doesn't mineralize properly. It doesn't harden as it should.
Uh-huh.
And the main reason for that, usually it's a lack of vitamin D or maybe issues with how your body actually uses the vitamin D it has.
Okay.
And the result is, well, weaker bones, more fragile, more likely to fracture.
Bone matrix mineralization. That sounds pretty fundamental. Can you break that down a bit more? What's actually happening or not happening?
Sure. So imagine your bone's framework, the osteoid, mostly collagen, right? Like
Yeah.
the scaffolding of a building.
Right.
Now, to make that scaffolding strong, you need to add the concrete, the minerals. In bones, that's mainly calcium and phosphate, which form crystals called hydroxyapatite.
Hydroxyapatite. Got it.
Mineralization is just the process of depositing those hydroxyapatite crystals onto that collagen framework. And for this to happen effectively, you need enough calcium and phosphate available.
Okay.
And interestingly, you also need a slightly alkaline environment, the right chemical conditions, you could say, for those minerals to really lock onto the bone structure.
So it's about the quality of the bone, then not necessarily the amount of bone.
Exactly. Spot on. That's the crucial difference between osteomalacia and osteoporosis.
Ah, okay. Good distinction.
Yeah, osteoporosis is where you lose overall bone mass. The bones get thinner, more porous, like a sponge with bigger holes. Osteomalacia is different. You might have a normal amount of bone matrix, but it's soft because it hasn't hardened properly, like a brick that wasn't fired right in the kiln.
Good analogy.
And just a key point, especially for revision, in children, before their growth plates close, this exact same mineralization problem is called rickets.
Rickets for kids, osteomalacia for adults. Got it. So what's causing this mineralization failure? What are the main causes of osteomalacia?
Well, like we said, the number one culprit is usually vitamin D deficiency or problems with its metabolism, how the body processes it.
Okay.
And there are quite a few reasons why someone might become vitamin D deficient. We can actually use a memory aid for this. S-endiol-MGG.
Oh, I like a mnemonic. Okay, S-endiol-MGG. Break it down for us.
Right, so S is for sunlight, just not getting enough exposure to UV light. Our skin needs that to make vitamin D. Could be lifestyle, working indoors, or living up north.
Yeah, definitely relevant here.
D is for diet. Low intake of vitamin D-rich foods. I is for intestine like malabsorption problems, things like Crohn's disease, celiac disease. The gut just can't absorb the vitamin D properly.
Okay.
A is for age. As we get older, our skin gets less efficient at making vitamin D, and our kidneys might not activate it as well. L stands for liver and kidney diseases. These organs are absolutely vital for converting vitamin D into its active form. Problems there cause big issues.
Right.
M is for medications. Certain drugs, like some anti-epileptics, can interfere with vitamin D metabolism.
Okay.
The first G is for genetic disorders that mess with how the body handles vitamin D. And the second G is really just to reinforce gastrointestinal disorders because malabsorption is such a key factor.
That's a really helpful way to remember those causes. So vitamin D is clearly central. Can you explain a bit more about what it actually does for our bones?
Absolutely. So vitamin D's main job in this context is to help your intestines absorb calcium and phosphate from your food. Think of it like a key unlocking the door for these minerals to get into your bloodstream. It also helps regulate calcium levels in the blood generally,
Right.
making sure there's enough calcium not just for bones, but for nerves, muscles, everything.
Right.
But for bones specifically, without enough active vitamin D, you just don't absorb enough calcium and phosphate.
So you're short on building blocks.
Exactly. You lack the essential minerals needed to properly harden that osteoid framework, so not enough vitamin D leads directly to poor mineralization.
Makes total sense. Now, who is most likely to run into this problem? Who's most at risk?
Yeah, there are definitely groups and factors that increase the risk. And guess what? We've got another mnemonic.
Bring it on.
Okay, this one's a bit longer. Slim, AKLD, Togi, VF, HOB, Phi.
Wow. Okay. Let's unpack slim, AKLD, togi, VF, HOB, Phi, Phi.
Right. S, sunlight, again, insufficient exposure. L, low vitamin D diet,
Mhm.
IBD, celiac, those malabsorption disorders,
Mhm.
M, medications like phenobarbital, rifampin,
Ah,
advanced age,
yeah,
K, kidney or liver diseases.
yeah.
L, limited sun exposure. This covers several things. Having dark skin.
You mentioned that affects production.
Yes, people with South Asian, African, Caribbean, or Middle Eastern backgrounds
Yeah.
often need more sun exposure because melanin acts like a natural sunscreen.
Right.
Also under L is wearing clothing that covers most of the body or being institutionalized.
Right.
D reiterates dark skin. T, toddlers' children. Rapid growth phases. O, over 65s. G, geographical location. High latitudes, less strong sunlight.
Mhm.
V, vegan vegetarian diets. Fewer natural sources sometimes. F, family history, maybe a genetic link. H, housebound institutionalized, again, lack of sun.
Okay.
Obesity. Vitamin D can get trapped in fat tissue, making it less available. B, exclusive breastfeeding beyond 6 months without baby getting supplements.
Right.
F, face body covering, limiting sun.
Mm-hmm.
And increased demand, like during pregnancy.
That is a very comprehensive list. So going a bit deeper into the pathophysiology, we know it's about vitamin D and mineralization. Can you elaborate on the mechanism?
Sure. So fundamentally, it's that lack of vitamin D leading to impaired absorption of calcium and phosphate. This means lower levels of these minerals in the blood. And these minerals are absolutely essential to mineralize that osteoid, that bone framework.
Right.
So what happens is you get this buildup of unmineralized osteoid. It's like having the scaffolding up, but not enough concrete being laid down properly. The bone stays softer than it should be.
And that's osteomalacia in adults and rickets in kids.
Exactly. In children, because their bones are actively growing at the growth plates, this lack of mineralization messes with that growth process too, causing the characteristic bowing and other deformities we see in rickets.
You mentioned vitamin D metabolism earlier, the activation steps.
Yes. So vitamin D, whether you make it in your skin from sun, that's D3, or eat it, D2 or D3, it's not active straight away. It's fat soluble.
Okay.
It needs two main steps. First, SOP, the liver. It gets converted to 25-hydroxyvitamin D, or 25-OHD. This is the form we usually measure in blood tests to see your vitamin D status.
Right, the standard blood test.
Exactly. Then this 25-OHD travels mainly to the kidneys and some other tissues too, where it gets converted again, this time into the fully active form. 1025-dihydroxyvitamin D, or 1025-OH2D, sometimes called calcitriol.
Calcitriol, okay.
That's the form that does most of the work, like boosting calcium absorption in the gut. And this final step in the kidney is tightly controlled, mainly by parathyroid hormone, PTH.
PTH, how does that fit in?
Well, if your blood calcium levels drop, your parathyroid glands release more PTH. PTH then tells the kidneys, hey, activate more vitamin D to help absorb more calcium from your diet and also release some from your bones to bring blood levels back up. It's a feedback loop.
Clever system. And what levels are we aiming for in that blood test, the 25-OHD?
Generally, the thresholds used are below 25 nanomoles per liter.
Yeah?
That's what is usually considered deficient.
Okay, definitely too low.
Yes. Then between 25 and 50 nmol is often termed insufficient or inadequate. Maybe not frank deficiency, but not ideal for optimal bone health. And above 50 cermolo is generally considered sufficient for most people's bone health. Some might argue for slightly higher levels for other potential benefits, but over 50 is the usual target for sufficiency.
And besides bones, you mentioned other roles, neuromuscular function.
Yes, that's an important one. Vitamin D receptors are found in muscle tissue, and deficiency is strongly linked to muscle weakness, which is a common symptom in osteomalacia. It also plays roles in the immune system, cell growth. It's quite widespread.
Right.
But its critical, best established role is definitely in calcium and phosphate balance and bone mineralization.
Okay. Let's talk sunlight again. We know it's important, but how effective is it realistically, say, here in the UK?
It's potentially very effective, but with big caveats. UVB radiation from the sun hits your skin and converts a type of cholesterol into vitamin D3. That's the main source, maybe 90% for many people.
Wow, 90%.
Yeah, but effectiveness depends hugely on time of day, season, latitude, how far north you are, cloud cover, pollution, skin pigmentation, and age.
Lots of variables.
Exactly. So in the UK, roughly between October and late March or early April, the sunlight just isn't strong enough. The angle's wrong. Not if UVB gets through.
So no deep production in winter, basically.
Pretty much. In summer, though, short bursts of midday sun, maybe 10-20 minutes on arms and face, for someone with fair skin, can generate quite a lot, thousands of IOUs. But darker skin needs significantly longer exposure.
Right.
And older adult skin is less efficient, too. Plus, you have to balance it with avoiding sunburn, obviously.
Of course. So diet becomes more important then, especially in winter. What are the best food sources? You mentioned another mnemonic.
Yes. For dietary sources, FOLEMC.
FOLEMC.
F is for fatty or oily fish. Think salmon, mackerel, herring, sardines. They're the best natural sources. L is for liver. Cod liver oil is famously high in vitamin D, but liver itself contains some. E is for egg yolks, contains smaller amounts.
Okay.
M is for margarine, often fortified with vitamin D in the UK. And C is for fortified cereals. Some yogurts and other products might be fortified too. You have to check labels.
And milk. We often think of milk and calcium.
Milk and dairy are great for calcium, but actually naturally quite low in vitamin D unless they're specifically fortified. Infant formula is fortified, though.
Good to know. And what about supplements? What are the general recommendations?
Yeah, supplementation is often advised, especially during those autumn and winter months in the UK. Public Health England recommends adults consider taking a daily 10 microgram supplement. That's 400 international units, IU.
400 IU daily for adults in winter.
Yes, as a general recommendation. Certain groups, older adults, people with darker skin, those who cover up, housebound individuals, might benefit from taking that 400 IU year-round.
Okay.
For children, breastfed babies from birth to 1 year should get 8.5 to 10 micrograms daily. And kids aged 1 to 4 years, 10 micrograms daily. Higher doses are used for treating actual deficiency, obviously, under medical guidance.
We do sometimes hear about vitamin D being linked to preventing other things like autoimmune diseases or cancer. What's the evidence there?
That's a really active area of research. There have been observational studies suggesting links between low vitamin D and various conditions, autoimmune diseases, cardiovascular disease, some cancers, mental health issues. But when it comes to large-scale clinical trials, testing whether giving vitamin D supplements actually prevents these conditions in people with sufficient levels, the evidence is often inconclusive or doesn't show a clear benefit.
So the jury's still out on those wider benefits.
For many of them, yes.
Yeah.
The role in bone health is absolutely solid, but for the other potential effects, more research is definitely needed before making broad recommendations for supplementation just for those reasons.
Okay, that's clear. Now, if someone comes in with symptoms, bone pain, weakness, what else does a doctor need to rule out? What's on the differential diagnosis list?
Good question. It's crucial because symptoms can overlap. We need to think broadly. And yes, there's another mnemonic, ORO, cramp, PHFM.
Okay, let's decode it.
First O is osteoporosis. Different mechanism, but causes fractures, bone pain sometimes. R is renal osteodystrophy bone problems linked to chronic kidney disease.
Right.
Second O is other metabolic bone disorders, things like Paget's disease, hyperparathyroidism, even multiple myeloma.
Okay.
C is chronic excessive fluoride intake, less common, but can affect bones. R is rheumatoid arthritis. Joint pain can be confused with bone pain. A is aluminium toxicity, again, more specific situations. M is muscle disorders, muscular dystrophy, polymyositis, dermatomyositis causing weakness. P is polymyalgia rheumatica, muscle pain and stiffness, especially in older adults.
Okay.
H is hyperthyroidism. Thyroid issues can impact bones. F is fibromyalgia, widespread pain and fatigue. And the last M is malignant disease cancer spreading to bones is a critical one to rule out. Oh, and maybe etidronate overdose, though rare.
That really highlights why a proper workup is needed. How common is osteomalacia itself? What's the epidemiology like in the UK?
Well, actual diagnosed osteomalacia might not be super common compared to, say, osteoporosis. But the underlying vitamin D deficiency is very common in the UK.
Right.
We saw those stats, maybe 1 in 5 adults having low levels in winter. Children, too. Significant numbers are low, especially in winter.
So the potential is definitely there.
Exactly. Given the high prevalence of deficiency, especially in at-risk groups, older people, those with darker skin, limited sun exposure osteomalacia is certainly a relevant health issue here. It's probably underdiagnosed sometimes because the symptoms can be quite nonspecific initially.
Okay. Let's talk about the symptoms then. How does osteomalacia typically present? What should people and clinicians look out for?
The classic symptoms are diffuse bone pain, often described as a deep, dull ache. It can be widespread, hips, pelvis, lower back, ribs, legs.
Not just one specific spot usually.
Often not, no.
Yeah.
It can be quite generalized. And bone tenderness pain when pressure is applied to the bones, like the shins or ribs. Proximal muscle weakness is another key feature.
Proximal meaning?
Muscles closer to the center of the body, so shoulders, hips, thighs. People might notice difficulty getting up from a chair, climbing stairs, or even a sort of waddling gait.
Okay.
And then there's the increased risk of fractures. Sometimes a low impact fracture, like from a simple fall or even just twisting, might be the very first sign that something's wrong.
Yeah.
General fatigue is common too.
Are there specific clues in the patient's history that might point you towards vitamin D deficiency?
Definitely. You'd ask about diet, low intake of oily fish, eggs, fortified foods. Ask about sun exposure. Do they work indoors? Cover up for cultural reasons. Are they housebound? Any history of gut problems suggesting malabsorption, Crohn's, celiac, previous gut surgery, any known liver or kidney disease. Are they taking any relevant medications? These all raise the index of suspicion.
And you mentioned rickets in children earlier. How do their symptoms differ from adults with osteomalacia?
Yes, because children's bones are actively growing, the presentation is different. In rickets, you might see delayed milestones like walking. Skeletal deformities are classic bowed legs, knock knees, thickened wrists and ankles, bumps along the ribs called a ricketic rosary.
Ricketic rosary, okay.
I might be irritable, lethargic, have poor growth. Muscle weakness can occur too. And in severe cases, very low calcium can cause seizures or tetany muscle spasms, rarely even heart problems.
Wow, quite severe potentially.
Yes. Adults don't usually get the same kind of dramatic bone deformities unless it's been very severe and long-standing, but the pain, weakness, and fracture risk are the hallmarks. They might also show signs of low calcium, like tingling or muscle cramps if it's severe.
So if osteomalacia is suspected, what investigations are typically done?
The first step is usually blood tests. We need to check a few key things. Serum 25-hydroxyvitamin D, that's the main vitamin D level. Serum calcium and phosphate. Alkaline phosphatase, or ALP, that's often raised because the bone's trying to remodel. And parathyroid hormone, PTH.
And what pattern would you typically see in vitamin D deficient osteomalacia?
Typically, you'll find low 25 OHD levels confirming the deficiency. Calcium might be low, or sometimes low normal, because PTH kicks in to try and keep it up.
Ah, the compensation mechanism.
Exactly. Phosphate is usually low, alkaline phosphatase is typically elevated, and PTH is usually high, reflecting that secondary hyperparathyroidism, trying to correct the low calcium.
Okay, that pattern makes sense. What about imaging?
X-rays are important. We look for general signs of poor mineralization, like thinning of the bone cortex. But the classic finding, though not always present, are pseudofractures, or looser zones.
Looser zones.
Yeah, they look like little cracks or lines, often perpendicular to the bone surface, usually symmetrical on both sides of the body. Common sites are the neck of the femur, pelvis, ribs, scapula. They represent stress fractures through poorly mineralized bone.
Interesting. Any other tests?
Well, a bone density scan, DXA, might be done. It often shows low bone density, osteopenia, or even osteoporosis, but it doesn't specifically diagnose osteomalacia.
Right.
And depending on the context, further blood tests might be needed to investigate the cause of the deficiency, like kidney and liver function, coeliac screen, if malabsorption is suspected.
Okay.
In children with rickets, a wrist X-ray is very useful to see changes at the growth plates. Very rarely, if the diagnosis is really unclear, a bone biopsy might be considered to directly look for that unmineralized osteoid, but that's not routine.
Got it. So once you have the diagnosis, how is osteomalacia managed?
The absolute core principle is to correct the underlying problem, usually the vitamin D deficiency.
Right.
So the mainstays are vitamin D supplementation, ensuring adequate calcium intake, often with supplements too, and if possible, addressing any factors contributing to the deficiency, like treating malabsorption or advising on safe sun exposure.
So it's primarily about getting those vitamin D levels back up.
Yes, that's the primary therapeutic goal. Replenish the body's stores, get the levels into the sufficient range, and allow normal bone mineralization to restart.
How is that done typically? Just supplements?
Usually with oral vitamin D3, cholecalciferol. The dose and duration depend on how severe the deficiency is. Often, a higher loading dose regimen is used initially for a few weeks or months to quickly build levels up, followed by a lower maintenance dose.
Loading than maintenance.
Okay. And calcium supplements are often given alongside, especially if dietary intake is low or calcium levels are low, to provide the necessary building blocks for mineralization. It's crucial to monitor the response.
How do you monitor?
Repeat blood tests, checking vitamin D levels to see if they're rising appropriately, checking calcium and phosphate levels to ensure they're normalizing, and watching the PTH. It should start coming down as vitamin D and calcium levels improve.
Right.
It's also important to monitor calcium levels to avoid overtreatment, which could lead to hypercalcemia, too much calcium in the blood. Sometimes urine calcium might be checked too.
And what about lifestyle, sun and diet?
Still important. While supplements are key for treatment, lifestyle advice is crucial for long-term health and prevention. Encouraging safe, sensible sun exposure during the summer months, advising on dietary sources of vitamin D and calcium. A balanced diet overall is always good for bone health. These support the treatment and help prevent recurrence.
So prevention of recurrence, that involves long-term strategies.
Yes, once the deficiency is corrected, many people, especially those with ongoing risk factors, will need to continue with a lower maintenance dose of vitamin D long-term.
Okay.
Plus maintaining those lifestyle factors, sensible sun, good diet. The goal is to keep vitamin D levels sufficient consistently.
Are there specific prescribing principles doctors follow?
Key things are: identify and treat the underlying cause if possible. Use an appropriate vitamin D loading regimen if needed, followed by maintenance. Ensure adequate calcium intake. Monitor the response with blood tests, vitamin D, calcium, phosphate, PTH, and watch out for hypercalcemia.
Right.
And in complex cases, severe kidney disease, parathyroid problems, uncertainty about diagnosis, getting specialist advice is important.
Does the approach differ much between treating rickets in children and osteomalacia in adults?
The principles are the same. Correct the deficiency, ensure calcium. But the dosing strategies might differ slightly. Children often get fixed loading doses based on age to promote rapid healing, followed by maintenance.
Okay.
Adults might also get loading doses, especially if symptoms are severe, then typically move to maintenance doses like 800 to 2,000 IU daily, sometimes up to 4,000 IU in specific cases, often manageable with over-the-counter supplements once stable. Monitoring in kids also focuses heavily on growth.
What's the overall outlook? What's the prognosis like for someone treated for osteomalacia?
Generally, it's very good with treatment.
That's encouraging.
Yeah, most people see a significant improvement, often complete resolution of bone pain and muscle weakness. Bone healing starts pretty quickly, within weeks, although full mineralization might take 6 months or more. The risk of fractures reduces dramatically.
Does it depend on how severe it was?
Yes, the outcome can depend on the severity and duration of the deficiency before treatment, and also on other coexisting health problems. But overall, treatment is usually very effective. People often report feeling much stronger and more mobile.
Do some people need treatment long-term?
Yes, as we mentioned, those with persistent risk factors, ongoing malabsorption, very limited sun exposure due to lifestyle or location, certain medical conditions, they might need lifelong, low-dose vitamin D maintenance therapy and regular checkups.
Okay. From a public health view, how can we prevent deficiency in the first place?
It's about awareness and access. Promoting sensible sun exposure, encouraging intake of vitamin D-rich foods, potentially food certification policies, and clear guidance on supplementation, especially for at-risk groups. The 400 IU daily recommendation for adults in the UK, specific advice for infants, children, pregnant women, older adults. Early diagnosis and treatment of underlying causes like celiac disease is also key.
We hear a lot about vitamin D preventing falls and fractures in general, especially in older people. What's the latest on that?
It's a bit nuanced. While vitamin D is essential if you're deficient, large studies looking at general populations, including older adults without severe deficiency, haven't always shown a significant benefit of routine vitamin D supplementation for preventing fractures or falls.
Oh, interesting.
Yeah, a major Lancet review, for example, found limited support for supplementation preventing fractures in the general community-dwelling population. So it's crucial for osteomalacia and deficiency, but maybe not a magic bullet for all fractures in everyone. The focus should probably be on identifying and treating those who are actually deficient or at high risk.
Good point. Finally, what happens if osteomalacia isn't treated? What are the complications?
Well, the symptoms worsen. Persistent, potentially debilitating bone pain, increasing muscle weakness, which really impacts mobility and quality of life, and increases the risk of falls. The fracture risk remains high, and multiple fractures can occur. In very severe, long-standing cases, permanent bone deformities can result. There's also the potential link with worse outcomes for other conditions, possibly increased risk of osteoporosis long-term, maybe cardiovascular issues. It definitely needs treating.
Okay, so let's quickly recap the main points. Osteomalacia is essentially bone softening, mostly caused by vitamin D deficiency messing up that crucial mineralization process.
Exactly. Key is understanding the risk factors: lack of sun, poor diet, gut issues, kidney liver problems, age, darker skin.
Right. And recognizing the symptoms: diffuse bone pain, muscle weakness, maybe fractures, and knowing that investigations, especially blood tests for vitamin D, calcium phosphate, ALP, and PTH, can confirm it.
And the good news is treatment with vitamin D and calcium is usually very effective. Prognosis is generally good.
Absolutely. So if any of this discussion has made you think or you want to dive deeper into bone health, we definitely encourage that.
And for those revising for exams, remember to check out the great resources at PathomsSARA.com.
And also freemsra.com for more helpful materials.
Definitely worth a look. So, maybe a final thought to leave you with.
Go on.
Given how vital vitamin D is for just keeping our bones strong and supporting our muscles, allowing us to stay active, are you personally giving enough thought to your own vitamin D status? Are you getting enough sun safely, eating the right foods, or considering supplements if you might be at risk? It's something quite fundamental to our well-being.
Definitely food for thought. Thanks for that deep dive.
My pleasure.